What if I told you that the blood sugar number your doctor is praising you for could be silently strangling your heart muscle? That the relentless chase for a perfect A1C is accelerating heart failure, triggering atrial fibrillation, and precipitating heart attacks in seniors right now? While your doctor congratulates you on your control, I'm Dr. Alan Whitman, a board-certified geriatrician. For over 22 years in my clinic, I've treated more than 4,000 senior patients. I've sat across from devastated families, reviewed thousands of charts, and I've watched a terrifying, consistent pattern emerge, a direct link between so-called good sugar control and catastrophic heart failure. By the end of this critical video, you will know the 3 hidden cardiac symptoms that scream your blood sugar is too low. You will learn the precise, age-specific A1C range that actually protects your heart instead of destroying it. And I will hand you my complete, step-by-step 5-step cardiac-safe sugar protocol, the exact framework I use in my practice. But I am not going to tell you that safe number yet. I am going to withhold it deliberately. Because if I just blurt out a digit without you understanding the profound physiological why behind it, you could walk away and make a decision that is not just wrong but deadly. First, I need you to participate. This is non-negotiable. In the comments below, I need you to type your last known A1C number and your current age, just the raw digits. Formatted like this: 6.2, 74 inches, or 7.8, 81. No stories yet, just the data. I need to see the landscape of who is watching and what you're currently dealing with. This is our starting point. Now, let me tell you about James. His story is going to change how you think about diabetes management forever. It's a story of perfect compliance, perfect numbers, and a perfectly preventable tragedy. James was 76 years old, a retired electrician, a man who worked with his hands his whole life. He was sharp, stubbornly independent, and physically robust. He built his own backyard deck at age 75. His only significant medical issue was type 2 diabetes, diagnosed about a decade earlier. And by all standard measures, he was a model patient. His A1C, the 3-month average of his blood sugar, was a textbook perfect 6.4%. Every time he saw his primary care doctor, he received praise. "James, you're my star patient. These numbers are exactly where we want them. Keep up the fantastic work." James existed in what I call the false security phase. He was given a clear, conventional goal: keep your A1C under 6.5% to protect your kidneys, your eyes, your nerves from the complications of diabetes. He accepted this mission with discipline. He took his 2 oral medications, metformin and glipizide, at the same time every day without fail. He became vigilant about sweets. He invested in a good home glucose monitor and checked his fasting sugar every single morning. The readout was consistently, reassuringly, between 90 and 110 milligrams per deciliter. "Perfect," he'd say to his wife, Martha. He felt the quiet pride of a job well done. But approximately a year into maintaining this ideal control, subtle cracks began to appear. These were the warning signs, and they were universally ignored. First, it was breathlessness. Walking up the slight incline of his driveway to get the mail left him winded, needing a moment to catch his breath at the top. He dismissed it. "I'm not as young as I used to be," he'd chuckle. Then he noticed his ankles were swelling by the end of the day, leaving deep, pitting indentations from his sock elastic. His wife pointed out he was getting up to use the bathroom 3, sometimes 4 times a night. He waved it off. "It's just the old prostate, nothing to do with the sugar." The most insidious symptom, however, was a profound and novel fatigue. This wasn't normal tiredness. He described it to Martha as a heart-heavy exhaustion, a feeling that his internal battery could never charge above 10%. "It's like I'm dragging a weight around in my chest," he confessed. At his next quarterly checkup, James, ever the diligent reporter, mentioned these symptoms. "Doc, I get short of breath easy now, and I'm just so tired all the time." His doctor, a good and busy man, performed a cursory exam. He listened to James's heart with his stethoscope. "Sounds regular," he said. He ordered a routine EKG, which came back showing what was charted as normal sinus rhythm for age. The doctor's conclusion was reassuring and dismissive. "James, your heart sounds fine. The EKG is normal. At our age, some breathlessness is often just deconditioning. Maybe try to lose 5 pounds. But let's focus on the win. Your A1C came back at 6.3%. That's outstanding. Don't change a thing. You're doing everything right." The authority of the printed lab report, the single celebrated number, completely overruled the complex whispering narrative of James's own body. The crisis event occurred on a Tuesday afternoon in his home workshop. He was repairing a lamp. He bent down to pick up a wrench he'd dropped. As he straightened up, a violent, terrifying sensation erupted in his chest. His heart didn't merely race. It lost all rhythm, thrashed wildly like a bird in a cage, a chaotic fluttering panic. Accompanied by a wave of lightheadedness and nausea, it forced him to drop back onto his work stool. Martha found him minutes later, ashen-faced, clammy with cold sweat, his pulse under her fingers a rapid, irregular tattoo. The ambulance was called. In the emergency room, the diagnosis was immediate and serious: new onset atrial fibrillation with a rapid ventricular response. His heart's upper chambers were quivering uselessly at over 400 beats per minute, while the lower chambers raced at 150. His heart was in a state of inefficient, dangerous chaos. And the first blood test drawn in the ER? His glucose was 101 mg/dl. Perfect. The irony was cruel. This single event triggered the cascade to tragedy. The atrial fibrillation was merely the visible symptom of a deeper, silent pathology. A subsequent echocardiogram, an ultrasound of the heart, revealed the devastating truth. James had developed significant diastolic heart failure, also known as heart failure with preserved ejection fraction, HFpEF. His heart muscle had become stiff and non-compliant. It could contract well enough. His ejection fraction was a normal-looking 55%, but it could not relax properly to fill with blood for the next beat. This condition, diabetic cardiomyopathy, is a direct consequence of the metabolic madness of diabetes on heart muscle cells, but it is poorly screened for and even more poorly understood in general practice. His hospital stay set off a domino effect. He was started on a blood thinner to prevent strokes from the AFib and a diuretic, water pill, to strip the fluid from his legs and lungs. The hospital confinement, the fear, the medications, they deconditioned him. He lost crucial muscle mass. The man who built decks now looked at a flight of stairs with trepidation. The psychological blow was as severe as the physical one. His independence was crumbling. 6 months later, the cascade reached its end. James was readmitted to the hospital with acute decompensated heart failure. His stiff heart could no longer manage fluid, and his lungs filled with it, a condition called pulmonary edema. He struggled to breathe. Despite intensive treatment, he suffered a massive ischemic stroke 1 week into this admission, a fatal complication likely stemming from his atrial fibrillation. The man who had achieved perfect diabetic control was gone. Months after, his son, David, sat in my office. His grief was tempered by a raw, focused anger. "He was so proud of that damn number," David said, his voice tight. He followed their rules to the letter. They were so hyper-focused on the sugar, on winning the game on paper, that they completely missed his heart turning to concrete. Let me be clear. My father did not die from diabetes. He died from the over-treatment of diabetes. He died for a number on a chart. When I later pieced together James's full clinical timeline, I was devastated. Not surprised, I had seen this pattern before, but devastated by the sheer waste. This was not an act of God or bad luck. This was a systems failure, a cascade of well-intentioned but misguided medical priorities. This was completely preventable. Here is the tragic, clarifying truth. James's overzealous blood sugar control almost certainly contributed to the stiffening of his heart muscle. Chronic, even mild, low normal glucose levels, when combined with certain insulin-stimulating medications, can starve the energy-hungry heart muscle. The heart, metabolically inflexible from diabetes, cannot adapt. This state of energy deficit promotes inflammation and fibrosis, the laying down of scar tissue within the heart muscle itself. It becomes less a pump and more a stiff, leathery bag. James was never offered this critical trade-off, a slightly higher, safer A1C, in exchange for a functional, resilient heart. He was never told the trade existed. If this story resonates with a painful familiarity, if you've seen a similar preventable decline in someone you love, a fall, a sudden arrhythmia, a diagnosis of stiff heart after years of good control, I need you to comment below. Simply type the words, "preventable tragedy." Let's see how many of us have witnessed this failure. I read every single one, so this forces the urgent question. What is the right balance? How do we, as seniors, navigate the very real dangers of high blood sugar nerve damage, kidney failure, blindness, without inadvertently sacrificing our hearts to the cure? If 6.5% isn't the universal holy grail, what is? For decades, the reigning dogma in diabetology has been tight control. The mantra was simple, linear, and aggressive. Lower is better. Always. This philosophy was cemented by landmark studies like the UK Prospective Diabetes Study, UKPDS, and the Diabetes Control and Complications Trial, DCCT. These trials showed miraculous reductions in microvascular complications, retinopathy, neuropathy. In younger, often newly diagnosed diabetic patients, when A1C was pushed lower, the message was broadcast far and wide. Aggressive control saves organs. But, and this is the most critical but in senior healthcare, these seminal studies specifically excluded the elderly, the frail, and those with significant pre-existing heart disease. They were not studying your population, yet their findings were extrapolated and applied to everyone, creating a one-size-fits-all mandate, that is, for seniors, often a dangerous misfit. But here is what your doctor likely hasn't had the time or perhaps the latest training to explain clearly. The heart is a metabolically unique organ. It's an obligate, relentless consumer of fuel, beating over 100,000 times a day. It possesses metabolic flexibility. In a healthy state, it can seamlessly switch between burning fat and burning glucose for energy, depending on what's available. In a diabetic heart, this flexibility breaks down. The heart muscle becomes insulin resistant at the cellular level. It's like having a car engine that can no longer use gasoline efficiently, so it's forced to run on a dirtier, less efficient fuel. This dysfunction is at the core of why diabetes is a primary driver of heart disease. Let me break down the 4 specific physiological reasons why aggressively lowering A1C in seniors is uniquely dangerous, turning the lower is better paradigm on its head. Reason 1. The hypoglycemia unawareness crisis. As you age past 65, your body's elegant warning system for low blood sugar, hypoglycemia, begins to fail. The classic alarms, trembling, sweating, pounding heartbeat, intense hunger, become muted or disappear entirely. This is called hypoglycemia unawareness. The first sign of a low for you may not be the shakes. It may be confusion, slurred speech, a sudden loss of coordination leading to a fall, or a silent cardiac arrhythmia. A glucose level of 65 lmg/dl that you don't even feel can trigger a surge of adrenaline so powerful it throws your heart into atrial fibrillation or causes a profound spike in blood pressure, stressing fragile blood vessels in your brain and heart. Reason 2. The medication accumulation problem. Many first-line diabetes medications, particularly sulfonylureas like glipizide and glyburide, and insulin itself, work by forcefully pushing glucose out of the bloodstream and into cells. They are powerful and effective. However, in a senior, the body's pharmacokinetics change. Kidney function naturally declines with age, often silently. The kidneys are responsible for clearing many of these drugs from your system. A dose that was safe and effective at 60 can become a dangerous accumulating overdose at 78. This leads to chronic, recurrent, and unrecognized episodes of low blood sugar, especially at night. Your heart is subjected to repeated stressful glucose roller coasters it cannot tolerate. Reason 3. The heart-muscle metabolism shift and energy starvation. In diabetic cardiomyopathy, the heart muscle's ability to use its preferred fuel, glucose, is impaired, so it shifts to burning almost exclusively free fatty acids. This is an inefficient process that generates more toxic oxygen radicals, promotes inflammation, and directly stimulates the laying down of fibrous, stiffening scar tissue within the heart muscle wall. Now, imagine aggressively lowering blood glucose with medications in this scenario. You are restricting the primary fuel the ailing heart is already struggling to use without fixing the underlying metabolic defect. You are, effectively, energy-starving an already struggling engine. The result is not protection, it's accelerated stiffening and weakening. Reason 4. The hemodynamic collateral damage. Every single episode of hypoglycemia triggers a defensive hormonal storm. Your body, panicking, releases a flood of counter-regulatory hormones: adrenaline, epinephrine, cortisol, glucagon. Adrenaline is a potent vasoconstrictor and cardiac stimulant. It causes your heart rate to skyrocket and your blood pressure to surge. For an aging cardiovascular system with potentially stiff arteries and vulnerable plaque, this is akin to hitting the engine with a sledgehammer repeatedly. The sheer stress on blood vessels can rupture plaque, causing a heart attack. The strain on the heart muscle can trigger failure or arrhythmia. The treatment to prevent microvascular damage is, in this way, directly causing macrovascular heart and blood vessel damage. The research that shattered the old paradigm was the ACCORD trial, Action to Control Cardiovascular Risk in Diabetes, published in 2008. It was a massive, ambitious study designed to see if intensive glucose control, targeting an A1C under 6.0%, would reduce heart attacks and strokes in middle-aged and older diabetics. The trial was halted prematurely. Why? The intensive control group had a significantly higher all-cause mortality rate. More people died. Specifically, they had a higher rate of cardiovascular death. The medical community was stunned into silence, then into frantic reanalysis. Later, more nuanced analyses focusing on age subgroups revealed the truth. A pivotal 2019 review in the journal Diabetes Care synthesized data from all major trials. The finding was unequivocal. For seniors over 75 years of age, the mortality risk was lowest with A1C levels between 7.5% and 8.5%. The risk actually increased for those pushed to A1Cs below 7.0%. The J-shaped curve was undeniable. Too high is bad, but too low is worse. The sweet spot for longevity had moved up dramatically with advancing age. But here is the critical disconnect that harms patients every day. Most primary care doctors see an A1C of 7.8% in an 82-year-old and feel a twinge of guilt, thinking they are being too lax. They have been trained for decades in the lower is better church. They have not been retrained in the new gospel of individualized, age-appropriate, morbidity-aware goals. They mistake strategic, sophisticated permissiveness for negligence. It is not. It is the highest form of geriatric care, balancing competing risks to maximize function and longevity. Now, we are at a crucial engagement checkpoint. Before I reveal the specific framework and numbers, I need to hear from you. This data point is vital for my understanding. In the comments below, I want you to type two things: your current age and whether you have ever experienced a possible sign of nocturnal, nighttime hypoglycemia. Have you woken up with drenched night sweats, a pounding headache in the morning, a racing heart upon waking, confusion or vivid nightmares? Simply format it age, yes, or age, no. For example, 79, yes, or 72, no. This simple act helps me gauge the prevalence of this silent danger. I am reading every single comment. You are now rightly desperate for the answer. Enough with the physiology and the tragedy, doctor. What number should I be aiming for? Just tell me the A1C. I am going to give you the precise, evidence-based framework used by leading geriatric endocrinologists. But first, we must dismantle the magic number myth once and for all by looking at what the cold, hard research actually reveals for different populations. I cannot, in good conscience, just give you a digit. If I did, and you marched to your doctor demanding that one number without the context, you could instigate a dangerous and inappropriate change. Your neighbor's safe number could be your direct path to the emergency room. Let's break down three key studies that paint the full picture. Study number 1, the Veterans Affairs Diabetes Trial, VADT. This study focused on older veterans, average age 60, with long-standing, poorly controlled diabetes. It compared intensive glucose control, target A1C approximately, 6.9%, to standard control, tilde 8.4%. After nearly 6 years, it found no significant reduction in major cardiovascular events, heart attack, stroke, from intensive control. More tellingly, the intensive group suffered significantly higher rates of severe hypoglycemia and increased mortality in the early follow-up period. The takeaway: in an older, sicker population with established diabetes, pushing A1C lower provided no cardiovascular benefit but substantially increased immediate risk. Study number 2, a landmark 22 study in JAMA Internal Medicine analyzing nursing home residents with diabetes. The findings were stark and should change practice. Residents with the lowest A1Cs, less than 6.5%, had the highest mortality. The lowest mortality was observed in those with A1Cs between 7.0% and 8.0%. For the frailest among us, those in institutional care, a higher A1C was not a sign of poor management. It was associated with greater survival. The body, in its frailty, was revealing its need for a higher glucose reserve. Study number 3, the American Diabetes Association, ADAD, Standards of Medical Care in Diabetes. the very guidelines doctors follow. If you dig into the 22-3 edition, in Section 12, Older Adults, you will find this critical, under-publicized language. Less stringent A1C goals, such as less than 8.0% or even higher, are appropriate for patients with advanced age. It also emphasizes avoiding hypoglycemia is a higher priority than achieving a low A1C in older adults. The guidelines have officially shifted, but the day-to-day practice in countless clinics has not caught up. You are likely being treated by an outdated standard. I am still not giving one number, because your body is not a lab specimen. It is a complex individual history. Let me illustrate with 3 anonymized, real patient profiles from my own practice. Patient profile number 1. Margaret, age 68. She is generally robust. Her diabetes is her only major chronic condition. She walks 3 miles daily, plays with her grandchildren, and has no history of heart disease, falls, or cognitive issues. For Margaret, we collaboratively set a target range of 6.5% to 7.2%. She uses a CGM, experiences no lows, and feels energetic and sharp in this zone. We can comfortably aim for the lower end of the senior spectrum because her physiologic reserve is high. Patient profile number 2. Leonard, age 79. He has stable coronary artery disease, with 2 stents placed 5 years ago. He has mild osteoarthritis, but is active. For Leonard, the calculus changes dramatically. A hypoglycemic event for him is not just an inconvenience, it is a potential trigger for a fatal heart attack. The adrenaline surge from a low could rupture plaque in his stented arteries. Therefore, his target range is intentionally higher, 7.0 to 7.8%. Our primary goal is absolute stability to avoid any glucose dips. His heart safety trumps a marginally lower A1C every single time. Patient profile number 3. Agnes, age 84. She is frail. She uses a rollator walker due to osteoporosis and a prior fear of falling. She has mild cognitive impairment. Her life expectancy is limited, and her quality of life is paramount. For Agnes, our target is unequivocally 7.5 to 8.5%. We have one non-negotiable rule: avoid hypoglycemia at all costs. A single low blood sugar-induced fall could mean a hip fracture, hospitalization, precipitous decline, and death. Confusion from a low could permanently worsen her cognition. At an A1C of 8.0, she is alert, stable, free of dizziness, and able to enjoy her family. This is not giving up. This is practicing expert, compassionate, goal-concordant care. See the profound difference? Healthier, younger seniors can tolerate lower targets. Older seniors with heart disease or frailty require higher targets for safety. It is a sliding scale of risk versus benefit. Now, I will give you the framework. This is the categorization I use to start the conversation with every new senior diabetic patient. You must use this as a starting point for a discussion with your doctor, not as a prescription. Category 1. The generally robust senior, ages 6075. No history of clinical heart disease, heart attack, heart failure, significant arrhythmia, no history of severe hypoglycemia or falls, cognitively intact and physically active. Target A1C range, 6.5% minus 7.5%. You may aim for the lower end of this range if you monitor closely and experience no lows. The upper end is perfectly acceptable if it provides stability. Category 2, the senior with heart conditions or high fall risk, ages 70-85. This includes diagnosed heart failure, especially HFpEF, atrial fibrillation, coronary artery disease, or a significant history of falls or dizziness. Target A1C range 7.0% minus 8.0%. This is the most critical category to get right. Your heart's vulnerability mandates a higher, safer floor. The priority is avoiding the hypoglycemic stress that can literally break your heart. Category 3. The frail elder or senior with advanced comorbidities. Age 80 plus or any age with significant frailty, dementia, multiple chronic conditions, or limited life expectancy. Target A1C range 7.5% minus 8.5%. The primary goals are to avoid symptoms of hyperglycemia, excessive thirst, urination, and above all, to avoid hypoglycemia completely. Quality of life, dignity, and stability are the sole metrics of success. I need you to internalize this. Then, I need you to engage. Comment below with the category you believe you currently fall into. Use this exact format, Category 2, age 78, AFib, or Category 1, age 71, healthy, or Category 3, age 85, frailty. This self-assessment is the first step in taking informed control. Knowledge is powerless without action. Now, I will give you my complete 5-step cardiac safe sugar protocol. This is the exact sequence I walk through with patients in my clinic. You will need to bookmark this section, take notes, or come back to it. This is your playbook. Protocol Introduction. You are transitioning from a passive recipient of care to an informed collaborative partner. You are not firing your doctor. You are equipping yourself with data to have a higher-level life-saving conversation. This protocol is about gathering objective evidence to guide smarter, safer decisions. Step 1. The Continuous Glucose Monitor (CGM) Advocacy Conversation. Your first mission is to discuss a CGM with your doctor at your very next appointment. A CGM is a small sensor worn on the back of the arm or abdomen that measures glucose levels in interstitial fluid every 5 minutes, providing a real-time graph on your phone or reader. For seniors, this is not a luxury, it is a safety-critical diagnostic tool. It shows trends, the terrifying dips that single finger sticks miss. It reveals nocturnal hypoglycemia. You must frame the request strategically. Do not say, "I want one." Say, "Doctor, I am increasingly concerned about the risk of undetected hypoglycemia, especially at night, and its potential impact on my heart. I've read about CGMs. Could we prescribe one, even temporarily, for 4 weeks to gather data on my glucose patterns? I want to ensure my current regimen isn't causing dangerous lows we can't see." This frames it as a collaborative safety check. Many insurance plans, including Medicare, now cover CGMs for diabetics on insulin, and increasingly for those on medications with high hypoglycemia risk. Step 2. The Comprehensive Medication Safety Audit. During the same visit, conduct a formal audit of your diabetes medications. Bring an exact list. For each one, ask your doctor this specific question. What is this medication's risk of causing hypoglycemia? And does it have any known cardiovascular benefits or risks? You need to understand the profile of what you're taking. High hypoglycemia risk, sulfonylureas, glipizide, glimepiride, meglitinides, repaglinide, and insulin. Low hypoglycemia risk / potential cardiovascular benefit, metformin, first-line well-established, SGLT2 inhibitors, empagliflozin, dapagliflozin proven to reduce heart failure hospitalizations, GLP-1 receptor agonists, semaglutide, liraglutide, proven to reduce heart attacks and strokes. The goal of this audit is to begin a conversation about potentially deprescribing or reducing high-risk drugs and exploring a transition to cardioprotective medications that allow for a gentler, safer A1C target with minimal low blood sugar risk. Step 3. Establish your time in range TIRE goal. We are moving beyond the static quarterly A1C. Your new dynamic metric is time in range. This is the percentage of time your glucose spends in a safe zone, typically defined for seniors as between 100 mg/dl and 180 mg/dl. You get this data from your CGM or from meticulous fingerstick checks. Though it's harder, here is the paradigm shift. An A1C of 7.5% with a time in range of 85%, meaning you're almost always between 100, 180, is infinitely healthier and safer than an A1C of 6.5 with a time in range of 50%, meaning you're bouncing high and, critically, dropping low half the time. Work with your doctor to aim for a TIR of greater than 70% while minimizing time below 70 mg/dl to less than 1%. This is personalized real-world control. Step 4. The 2-week heart symptom synchronization log. For a period of 2 weeks, you will keep a dual diary. In one column, log your glucose readings from CGM or meter at key times. Fasting, 2 hours after meals and before bed. In the adjacent column, log 2 key cardiac metrics. 1. Your resting heart rate. Use a smartwatch finger pulse oximeter or manual pulse check. And 2. Your subjective feeling of shortness of breath on a standard activity, e.g., walking to mailbox, mild SOB. The goal is to detect correlations. Do you see a spike in heart rate or breathlessness 2-3 hours after taking your diabetes medication? Do you wake with a racing heart when your nocturnal glucose graph shows a dip? This log creates irrefutable, personal evidence linking your glucose management to your cardiac well-being. Step 5. The Collaborative Care Bridge Meeting. If you are under the care of both a cardiologist and a primary care doctor or endocrinologist, you must become the conduit between them. This step is non-negotiable. Schedule appointments with both. Close together. Bring your CGM reports and your heart symptom sync log to each. Your script for the cardiologist. My other doctor is focusing on a low A1C. Here is my CGM data showing I'm having frequent lows, especially at night. And here's my log showing correlating heart palpitations. I am concerned this is straining my heart. What A1C range do you think is safest for my specific heart condition? Your script for the primary/endo. My cardiologist is concerned about my heart failure/AFib. Given this CGM data showing hypoglycemia, can we agree to adjust my target to a heart-safe range of X to Y to eliminate these lows? You are not playing one against the other. You are facilitating a unified, patient-centered care plan. Now, let me preemptively address the most common fears and questions. Q1. If I let my A1C go up to 8.0%, won't I go blind or need dialysis? Understand this. The relationship between A1C and microvascular complications is a curve, not a straight line. The UK PDS study showed that the greatest reduction in risk for eye and kidney disease occurs when you lower A1C from very high levels, e.g., 9% plus, down to around 7.0-7.5%. The additional benefit gained by pushing from 7.5% down to 6.5% is relatively small. However, the risk of severe hypoglycemia increases exponentially in that same lower range. For a senior, We choose the point on the curve that gives us substantial microvascular protection, achieved by approximately 7.5%, while avoiding the steep cliff of hypoglycemia and cardiac risk that lies below it. We are not abandoning protection. We are optimizing it for your whole body. Q2. I don't like gadgets. Can't I just check my sugar more often with a finger stick? You can, but you must do it strategically. Finger sticks give you single data points, not the trend. If you rely solely on them, you must check at these non-traditional critical times. 1, 2, 3 hours after taking your diabetes medication to catch post-dose lows, and 2, at 3 a.m. once or twice a week to unmask nocturnal hypoglycemia. The fasting and pre-meal checks most people do are almost useless for detecting the dangerous lows that matter for your heart. Q3. My friend is on a keto diet and reversed her diabetes. Should I try that? I must be unequivocal. For a senior on glucose-lowering medications, a sudden drastic reduction in carbohydrate intake is extremely dangerous. It can lead to profound, unpredictable, and severe hypoglycemia. The goal is not ketosis. It is glucose stability. Focus on a consistent, balanced diet with complex carbohydrates, non-starchy vegetables, legumes, whole grains, lean protein, and healthy fats spread evenly across meals. Meal consistency is far more important than radical restriction. Q4. What about all the new wonder drugs I hear about? Are they safe for my heart? This is where medicine has made revolutionary progress. The SGLT2 inhibitor class, drugs ending in flozin, and the GLP-1 agonist class, drugs ending in tide, are not just glucose lowers. In large cardiovascular outcome trials, they have proven to reduce the risk of heart attack, stroke, cardiovascular death, and heart failure hospitalization. For a senior with diabetes and heart concerns, discussing a transition to one of these medications, if kidney function allows, is one of the most important conversations you can have. They typically cause little to no hypoglycemia, support a higher, safer A1C target, and directly protect the heart. Q5. When is high blood sugar a true medical emergency for a senior? True diabetic emergencies are typically marked by very high blood sugar and specific symptoms. If your glucose is over 300, 400 mg/dL and you are experiencing persistent vomiting, profound dehydration, confusion, or rapid breathing, Kussmaul respirations, seek immediate medical attention. This could indicate diabetic ketoacidosis, more common in type 1, or hyperosmolar hyperglycemic state, more common in type 2 seniors. Importantly, a high number alone, e.g., 250 without symptoms, is not an ER-level emergency. It is a sign to call your doctor within 8 hours to adjust therapy. I must end this section with the most critical disclaimer. Never, ever initiate, stop, or change the dosage of any prescription medication based on information in this video without a detailed, explicit conversation with your prescribing physician. You are empowering yourself with data and questions, not with a license to self-prescribe. Sudden changes can be lethal. Let me leave you not with tragedy, but with transformative hope. Let me tell you about Patricia. She is the luminous counterpart to James's story, living proof that when knowledge is applied with courage and collaboration, we can reverse decline and reclaim life. Patricia was 81 when she was referred to me. She had a history of type 2 diabetes and a recent terrifying diagnosis of heart failure with preserved ejection fraction, the same stiff heart syndrome. She had suffered 3 unexplained falls in 6 months. Her previous doctor had her on glipizide, diligently chasing an A1C of 6.8%. She was controlled, but she was also frightened, exhausted, and shrinking from her own life. We initiated the 5-step protocol immediately. Step 1. We got her a CGM. The 2-week graph was a revelation and a horror. It showed multiple, silent plunges into the 50s and 60s every single night between 2 a.m. and 4 a.m. Her heart was being ambushed during sleep every night. Step 2. We audited her medications. The glipizide was the clear culprit. Step 3. We established a new goal, not an A1C number, but a time and range goal of greater than 80% above 100 mg/dl, with 0 time below 70. Step 4. Her symptom log already showed her morning fatigue and confusion correlated perfectly with those nocturnal dips. We had the conversation. I explained the J-curve, the stiff heart, the adrenaline storm. We agreed on a new, heart-safe A1C target of 7.5 to 8.0%. We slowly, carefully weaned her off the glipizide and initiated a low dose of a GLP, one receptor agonist chosen for its low hypoglycemia risk and proven cardiovascular benefit. The transformation was not subtle. Within 2 weeks of stopping the glipizide, the nocturnal lows on her CGM disappeared. The line flattened into a gentle, safe wave. She called me, her voice trembling with emotion. I slept through the night. I woke up and the room was clear. My heart wasn't pounding in my chest. I felt calm. At her 3-month follow-up, her A1C was a stable, intentional 7.9%. Her time in range was 88%. The swelling in her ankles had resolved without increasing her diuretic. Her reported energy score went from a 2 to a 4. Most importantly, she had 0 falls. 6 months into her new regimen, she had a follow-up echocardiogram. The cardiologist's note read, mild improvement in diastolic parameters. Patient reports significant symptomatic improvement. The stiff heart was getting a little more flexible, not from a stronger squeeze, but from being allowed to operate without the constant stress of fuel shortages and adrenaline bombardments. Today, at 82, Patricia's A1C floats gently between 7.7% and 8.1%. She is not a perfect diabetic by old standards. She is a thriving, heart-safe senior. She resumed her water aerobics class. She took a trip with her daughter to see the fall colors. Her testimony is what fuels my work. I was killing myself trying to be the perfect diabetic. I was following the map, but it was leading me off a cliff. Dr. Whitman didn't give me a new number. He gave me a new compass. He asked how I felt, not just what the machine said. My doctors now work with me. I got my life back, and I won't let a pointless number take it from me again. I hold James's story in my heart, a solemn reminder of the devastating cost of getting this wrong. I also hold Patricia's story there, a beacon of what is possible when we have the courage to challenge outdated dogma and listen to the wisdom of the individual body. If James had possessed the knowledge you now hold, he would be in his workshop building something beautiful. That is why I made this video. You are now armed. You possess knowledge that is still not mainstream in countless clinics. Let's crystallize your power. You understand that the relationship between A1C and health in seniors is a J-shaped curve. Too low is as dangerous, if not more so, than too high. You know your personalized perfect is not 6.5, but a range determined by your age, heart health, and frailty status. Categories you can now name. You have the complete 5-step cardiac-safe sugar protocol, from CGM advocacy to medication audits to bridging specialist care. You can now interpret your body's whispers, nocturnal sweats, morning fatigue, unexplained breathlessness, as the critical warnings they are. This information is potential energy. It only becomes kinetic, life-changing power when you act. Here is your immediate action plan. First, within the next 7 days, schedule the appointment to discuss a CGM and a medication audit with your doctor. Second, before that appointment, write down your category from Act 4 and your 3 most pressing questions. Third, begin the shift in your own mind. Success is stable, alert, and independent, not a number on a lab slip. Before you close this video, I need you to do 3 final things for me, for this community, and for yourself. Subscribe to this channel. Click the button below. My mission is to dismantle dangerous, one-size-fits-all senior health advice and rebuild it with nuance, evidence, and deep respect for your stage of life. Every week I publish a deep dive like this on cholesterol myths, arthritis solutions, medication pitfalls, always through the lens of geriatric wisdom. Share this video strategically. Do not just post it publicly. Send it in a private message to your spouse, your siblings, your closest friends over 60. Attach a note. This made me rethink everything about my diabetes and heart. Can we watch it and talk? This information has the power to save a life, preserve an independence, and prevent a cascade of tragedy. Leave one final defining comment below. Tell me your next step by choosing one of 3 options. Comment heart first if you are committing to a heart-protective A1C target. Comment CGM data if your first action is to seek continuous glucose monitoring. Or comment for James as a tribute to the man we lost to the old paradigm, and a pledge that you will use this knowledge to write a different story for yourself. Thank you for trusting me with your time and your health. This is a partnership. Remember, your body tells a complex, beautiful story. Your job is to listen to it closely. Your doctor's job is to help you interpret it wisely. Together, you can write an ending of strength and vitality. I am Dr. Alan Whitman. Stay strong. Stay informed. I'll see you in the next video. Disclaimer: the content in this video is for educational and informational purposes only, and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have seen in this video. Do not initiate, change, or stop any medical treatment or medication based on the information presented here. Always consult with your personal physician before making any healthcare decisions.